Okay, let's unpack this. Welcome to the deep dive. Today, we are cracking open a really specific and important topic, especially if you're knee-deep in medical revision. We're diving into syringomyelia, taking your stack of notes and pulling out the absolute, well, the high-yield essentials you need to know. Think of this as your revision shortcut. We're going to try and filter out the noise and focus on the core facts, the insights, the surprising details right from your source material. It's all about getting you well informed on this condition quickly and effectively.
Yeah, and Syringomyelia is a perfect candidate for this kind of, focused deep dive. As your notes lay it out, it's fundamentally about a fluid-filled space, a syrinx, developing inside the spinal cord.
Yeah.
But understanding its intricacies, why it forms, what specific problems it causes, and crucially, how it's managed, that's vital, especially for exam scenarios. So we're going to walk through your notes section by section, connect the dots on all the critical areas.
All right, let's jump right in then. So the very first thing in the notes is the definition. At its core, what is syringomyelia?
Well, the material defines it pretty precisely. It's the presence of that fluid-filled cavity, that syrinx, within the substance of the spinal cord itself.
And right away, the notes point to a frequent association, don't they? A common cause.
They do, yeah. There's a strong association with structural problems, and the most common one highlighted is Chiari malformation. These issues, they interfere with the normal flow of cerebrospinal fluid, or CSF, around the brain and spinal cord. And as that syrinx cavity expands over time, it compresses the surrounding spinal cord tissue, and that compression is what generates the symptoms. Your notes also rightly point out that this condition typically requires ongoing management.
Got it. Syrinx in the cord, often linked to Chiari, CSF flow disruption.
Right.
And there's a term for when this goes higher up into the brainstem.
Yes, that's syringobulbia. It's essentially the same kind of fluid-filled cavity, but located specifically within the brainstem. Your sources mentioned it can sometimes occur alongside or, as an extension of a spinal syrinx.
Okay, so getting that initial picture is key. Fluid cavity, spinal cord, often connected to structural issues affecting CSF. That's our foundation.
Exactly. It really is the starting point for everything else we'll discuss about the condition.
All right, let's dig into why this happens. What are the specific causes, the etiologies, and the risk factors listed in your notes? What actually triggers this process?
Okay, so your material lists several key drivers. Leading the list, as we mentioned, is Chiari malformation, particularly Chiari of the West. That's where parts of the cerebellum sit a bit lower than they should, potentially blocking CSF flow right at the base of the skull. Spinal cord trauma is another major one. An injury can disrupt tissue and those CSF pathways. Then there are tumors, though they're noted as less common causes themselves, especially those within the spinal cord, the intramedullary tumors. They can lead to a syrinx by blocking flow or altering pressure. And more broadly, really anything causing disruption or blockage of CSF circulation can do it. Things like arachnoiditis, that's inflammation of the membrane around the cord.
Right, the arachnoid mater.
Exactly. Or meningeal carcinomatosis,
Yeah.
where cancer cells spread to that membrane, or, other types of space-occupying lesions pressing on the cord. And logically, these causes largely mirror the risk factors mentioned in the notes. Having a Chiari malformation, a history of spinal cord trauma. Family history is also noted, though the familial form, which is autosomal recessive, is presented as quite rare.
The notes also list other associations: spina bifida, post-traumatic syringomyelia reinforcing the trauma-linked arachnoiditis again, spinal dysraphism, which is problems with spinal development, scoliosis, and Klippel-Feil syndrome. And then there's idiopathic syringomyelia, so cases where we just don't find a clear cause.
Correct. Idiopathic cases actually account for a significant percentage, something like 16%, according to one note. It shows we don't always find a clear why. But what really stands out in your notes, and it's worth repeating, is how frequently Chiari malformation comes up. It's clearly a very common underlying cause to keep in mind. And understanding the cause is absolutely essential because, as we'll see when we get to management, the treatment is usually aimed squarely at fixing that root problem.
That makes perfect sense. Treat the source, not just the syrinx itself. Now, what's the mechanism described in the notes? How does that blockage actually create the syrinx cavity?
Well, the core mechanism described really hinges on that CSF flow obstruction we talked about. The idea is when CSF can't flow normally, particularly downwards around the spinal cord, it seems to get sort of forced into the spinal cord tissue itself. It accumulates there and gradually expands to form the syrinx cavity. And the sources of this obstruction are the usual suspects again: Chiari, trauma, tumors. The physical impact is that this expanding syrinx acts like a balloon inflating inside a narrow tube. It compresses the delicate nerve tissue of the spinal cord. And that compression is precisely what disrupts the nerve signals traveling up and down the cord, leading directly to the patient's symptoms.
Your notes add a little caveat, though, that the exact mechanisms aren't fully understood, involving complex CSF dynamics and pressure changes.
Yes, and that's an important piece of nuance. There's still ongoing research here. But for your revision purposes, the key takeaway is really that sequence. Obstruction of CSF flow white leads to fluid accumulation and syrinx formation, which causes spinal cord compression ranks, resulting in disrupted nerve signals, and finally, symptoms. That pathway is pretty central to understanding the condition.
Okay, useful chain of events there. Let's switch gears slightly. If someone presents with symptoms that could be syringomyelia, what other conditions should be on, our differential list? What are the main mimics according to these notes?
Right, the differential diagnosis. The sources list conditions that could present with similar neurological deficits. These include multiple sclerosis, or MS, which affects myelin in the CNS, transverse myelitis, which is inflammation across a whole segment of the cord, intramedullary spinal cord tumors. These can cause cord compression and symptoms similar to a syrinx, and confusingly, they can also sometimes cause a secondary syrinx. And neurosyphilis, which is syphilis affecting the nervous system, that can cause various forms of cord damage.
And why is having this list handy so important for revision? Just knowing what else it might be.
Well, because in a clinical scenario or an exam question, symptoms are rarely entirely unique, are they? You really need to consider the possibilities. Knowing this differential helps you think about how investigations, like the MRI we'll discuss, will help you rule out these mimics and confirm syringomyelia, ideally by visualizing that characteristic syrinx and identifying its cause.
Right. Differential diagnosis is always key in neurology. Okay, let's look at the epidemiology. Who tends to get this, and how common is it actually?
Your notes state that the overall prevalence is unknown, which generally means it's considered a rare condition. The incidence, how often new cases occur, varies quite a bit depending heavily on the underlying cause. So for example, while Chiari malformation is relatively common, maybe around 1 in 1,000 people, only a subset of those individuals will actually go on to develop a syrinx.
And in terms of demographics, the notes say it's commonly diagnosed in young adults, sort of 20s to 30s, but can happen at any age. And there's that slight note about prevalence in males versus females that seems a little contradictory. One note says more in females, another more in men.
Yes, that's an interesting point from your sources, huh? One note does mention slightly more prevalent in females, while another states it's more common in men. It suggests there might be some variation or perhaps debate in the data, or maybe it depends on the underlying cause. It's a good detail to note for critical revision, that slight discrepancy. Location-wise, most syrinxes are cervicothoracic, so they affect the spinal cord in the neck and the upper back region. Again, Chiari theirs is reinforced as a common cause. Your notes give some percentages too. Trauma accounts for about 7.5% of cases, and remember that 16% are classified as idiopathic, meaning no known cause is found.
Remembering these stats and demographics, even the slightly conflicting ones, it helps build that typical patient picture, right? Even for a rare condition.
Absolutely. It gives you a framework when you're approaching a potential case or a question about it.
Okay, here's where it gets really interesting for revision, the clinical presentation. This is where the rubber meets the road. What specific signs and symptoms should you be looking for based on these notes? What does syringomyelia actually look like in a patient?
Yeah, this is definitely the high-yield section for recognition. Generally, symptoms usually begin around age 30 and tend to progress slowly. As we mentioned, it's most commonly diagnosed in the 20-30s range, but the age can vary. A notable point from your notes is that about 22% of cases are actually asymptomatic, often discovered incidentally on MRI for something else. And about half of those asymptomatic cases are linked to Chiari. When symptoms do occur, they're diverse because the syrinx can compress different nerve tracts within the spinal cord. Your notes break this down well: sensory disturbances, motor dysfunction, and autonomic issues. Basically, the widening syrinx compresses nerve fibers, leading to weakness, stiffness, pain, sometimes headaches, and loss of sensation. The exact symptoms depend heavily on the syrinx's location and its size, its extent. They're typically gradual in onset, but sudden worsening can occur. For example, if the syrinx maybe ruptures or suddenly expands during activities that spike pressure, like a strong sneeze or cough.
Let's really hone in on those symptom categories. Sensory features seem particularly important, almost pathognomonic sometimes.
They really are. The most classic and definitely the highest yield sensory feature from your notes is the loss of pain and temperature sensation. And crucially, this often happens in a shawl-like distribution across the shoulders, the upper arms, and the upper torso, like wearing a shawl. This distinctive pattern happens because the syrinx often expands centrally first, damaging the nerve fibers that cross over in the middle of the spinal cord. Those are the ones carrying pain and temperature signals before it affects other pathways like touch, proprioception. You can also see altered or decreased sensation like dysesthesia, those unpleasant abnormal sensations, and potentially loss of light touch, vibration, or position sense, often starting in the extremities, maybe the feet first.
Okay, so that shawl-like loss of pain temp is a major memory hook, definitely one to remember. What about motor findings?
Motor involvement often affects the upper limbs first, especially with those common cervicothoracic syrinxes. So you'll look for muscle wasting and weakness, commonly in the hands, the forearms, and the shoulders. This typically leads to loss of tendon reflexes in the affected areas, so lower motor neuron signs in the upper limbs. The notes specifically mention a possible claw-hand deformity developing due to that intrinsic hand muscle wasting. In more severe or extensive cases, there might even be involvement of the respiratory muscles, which is obviously serious.
And autonomic symptoms, what should we look for there?
Right, autonomic features point to damage to the autonomic pathways running within the cord. This can result in bladder problems, bowel issues, or sexual dysfunction. Your notes also list a rare but possible finding of Horner syndrome. The ptosis, meiosis, anadrosis, drooping eyelid, constricted pupil, decreased sweating on one side of the face. That can happen if the syrinx damages the sympathetic fibers as they travel through the cervical cord.
And if that syrinx actually extends up into the brainstem, that syringobulbia we mentioned earlier.
Yes. Then you're looking at potential cranial nerve symptoms. The notes mention things like facial sensory loss, which would involve the trigeminal nerve, CNV, or dizziness, vertigo, nystagmus problems with balance and eye movement involving the vestibulocochlear nerve complex, CN8. Weakness or paralysis of other cranial nerves, like the facial nerve or 9XX, affecting swallowing and shoulder movement, and even weakness or atrophy of the tongue involving the hypoglossal nerve, CN8-12.
The notes also list some other potential findings, like Charcot joints. That sounds quite severe.
It is. Charcot joints are basically severe joint destruction, often seen in the shoulder, elbow, or wrist in this context. It happens because of repeated unnoticed injuries due to that loss of pain and temperature sensation. The joint just gets worn down without the usual protective pain feedback. Also listed are scoliosis, which can be associated, painless ulcers on the hands for the same reason as the Charcot joints, and lower limb involvement if the syrinx extends downwards. That might manifest as lumbar spine extension issues or leg weakness, often more spastic in nature if upper motor neuron tracts are hit lower down. And, as you touched on, respiratory insufficiency is a potential serious outcome.
Right, those seem like important associated features, even if less consistent.
Definitely worth knowing.
And the notes wrap up this clinical section by explicitly listing distinctive features. These sound like the absolute must-knows for differentiating this condition in an exam or clinic.
They absolutely are. If you see these features clustering together, syringomyelia should be high on your list. Your notes highlight these key points. First, that dissociated sensory loss of temperature and pain, but preservation of light touch, proprioception, and vibration in the affected areas, especially that shawl distribution. That sensory dissociation is classic. Second, predominant lower limb spastic weakness. This might seem counterintuitive if the syrinx is high up in the cervical region, but it reflects damage to the descending upper motor neuron tracts affecting the legs. Third, neuropathic pain, often described as burning, tingling, or aching. Fourth, upgoing plantar reflexes the Babinski sign, which also points to upper motor neuron involvement, specifically the corticospinal tract. Fifth, the rare possibility of Horner syndrome we discussed. And sixth, bowel and bladder dysfunction reflecting autonomic pathway damage. These distinctive points are really golden nuggets for identification. And, as your notes emphasize, a careful, thorough neurological exam is absolutely essential to pick up on these specific patterns of deficits.
Those distinctive features are definitely the ones to commit to memory. So, okay, someone presents with this kind of constellation of symptoms. How do we actually confirm the diagnosis? What are the key investigations recommended in your note?
Right, confirmation. The primary diagnostic tool, the absolute gold standard here, is a full spine MRI, usually with contrast.
Yeah.
Your notes make this very clear because MRI directly visualizes the syrinx itself. You can see its size, its length, its precise location within the cord. It's also absolutely vital for ruling out other issues that could mimic a syrinx, or importantly be the cause of the syrinx, like those spinal cord tumors, or perhaps a tethered cord.
And you need to look higher up too, not just the spine.
Yes, exactly. A brain MRI is also considered required, specifically to check for and rule out a Chiari malformation, given how incredibly common it is as the underlying cause of syringomyelia. Finding the cause is paramount because it directs the treatment strategy. Your notes mention some additional imaging possibilities, though they're less common now. Things like CT scans, which might show tumors or related hydrocephalus, or myelography, which involves injecting contrast into the spinal canal, but this is rarely needed now that MRI is so good. Plain X-rays of the spine might occasionally show a widened spinal canal in the cervical region, which could be an indirect clue, but it's certainly not diagnostic.
And there's a really crucial procedural warning in the notes, isn't there? Something to avoid.
Yes, and it's a very important one for safety. Lumbar puncture, or spinal tap, is generally best avoided if you suspect syringomyelia. Your notes specifically warn about the risk of brainstem herniation, especially if there's raised intracranial pressure or if a structural issue like a Chiari malformation is present, which it often is. Altering the pressure dynamics from below can be dangerous.
Whoa, okay, so definitely avoid the LP in this scenario. Good to know.
Yeah, definitely. So reconfirming, MRI is the definitive method for visualization and helping identify the underlying cause. Knowing that MRI is the first line, go-to investigation is definitely a key point for your revision.
Okay, so we've diagnosed it, ideally found the cause with that essential MRI. What's the approach to managing syringomyelia based on your notes? What do we do about it?
The management strategy really centers, first and foremost, on addressing the underlying cause of the syrinx, if one is identified.
That makes perfect sense. Target the root problem. What about general measures? Supportive care?
Yet, general measures are important too. They include supportive care, like physiotherapy, and neurological rehabilitation. The goal there is to help preserve function, maintain strength, and improve mobility as much as possible. Patient education is also highlighted as really important, particularly making patients aware of their potential loss of pain sensation, so they can take precautions to avoid unintentional injuries, like burns or cuts they might not feel. And of course, managing symptoms like pain, often neuropathic pain, with appropriate analgesics is a key part of ongoing care. Now, for symptomatic cases, especially if the syrinx is clearly progressing or causing significant neurological deficits, surgery is typically the recommended approach. Your notes mentioned various neurosurgical procedures, and the choice really depends on what's causing the syrinx and where it is.
Okay, what are some of the specific surgical options described in the notes?
Well, options include directly shunting the syrinx fluid away to another body cavity, like the peritoneum or pleura. It's often called a syringoperitoneal or syringopleural shunt. Other procedures might involve a laminectomy, which is removing part of the vertebral bone to create more space around the spinal cord, or maybe a syringotomy, which is directly opening and draining the syrinx cavity itself. Tying it more specifically to causes. For Chiari malformation, the standard surgery is usually a surgical decompression at the foramen magnum, the opening at the base of the skull. This aims to restore normal CSF flow by creating more space there. That syringoperitoneal shunt we mentioned is often used for symptom relief and trying to halt progression when other methods aren't suitable or the cause is unclear. If a tumor is identified as the cause, then surgical removal of the tumor is obviously necessary. For trauma-related cases, surgery might involve expanding the space around the injured cord segment or removing scar tissue that's blocking CSF flow. Radiation therapy might be considered, but mainly in tumor-related cases. And a critical note that's emphasized repeatedly in your material is that timely treatment is absolutely crucial. It's needed to prevent irreversible spinal cord damage. The longer the cord remains compressed, the higher the risk of permanent neurological deficits.
Okay, so surgery is generally for those with symptoms and clear progression or deficits. What about those asymptomatic cases found incidentally, or those with very mild, stable symptoms? Do they all need surgery?
No, not necessarily. Your notes state that those cases are often managed more conservatively, with observation and careful monitoring. This involves regular clinical follow-ups and repeat imaging, like periodic MRIs, to catch any signs of syrinx enlargement or symptom development early, before significant damage occurs. And symptom management, as we touched on, using medications for pain, spasticity, neuropathic pain, plus physical and occupational therapy remains really important for improving quality of life, whether surgery is performed or not. So the general pathway seems to be: identify the cause with MRI. If symptomatic and progressive, consider surgery targeting the cause of the syrinx. If mild or asymptomatic, then usually watch and wait with monitoring, and always manage the symptoms actively.
That clear pathway based on the cause and the symptoms is really helpful for structuring the approach. Finally, what's the outlook for someone with syringomyelia? What do the notes say about the prognosis and the potential complications down the line?
Well, the prognosis is described as quite variable. It really depends heavily on several factors: the underlying cause, how much damage has already occurred to the spinal cord by the time of diagnosis, and critically, the timing of intervention. Your notes stress this point again. Early diagnosis and prompt treatment are crucial for preventing symptom progression and improving the likelihood of a better long-term outcome. Prognosis tends to be worse with larger syrinxes, certain locations within the cord, some specific causes, and of course, greater initial disability presentation. Importantly, early surgical intervention, when it's indicated for symptomatic patients, is generally associated with better outcomes compared to delaying treatment. Very rarely, your notes mention, a syrinx can spontaneously regress or get smaller on its own, but that's considered quite unusual.
And what about things going wrong, the potential complications that can arise from this?
Complications primarily stem from that progressive damage to the spinal cord tissue. They can include ongoing neurological deterioration, meaning symptoms just gradually worsen over time despite treatment. Associated conditions like scoliosis can develop or worsen, and if mobility becomes severely impaired, then all the complications related to immobility become a risk. Things like pneumonia, pressure sores, or blood clots like pulmonary embolism, PE. But the most serious complications are those directly related to the myelopathy itself, the damage to the spinal cord. These can be devastating, as listed in your notes. Paraplegia, which is paralysis of the legs, or even quadriplegia, paralysis of all four limbs, severe permanent bowel and bladder dysfunction, and potentially respiratory failure, either due to weakness of the breathing muscles or damage to the respiratory control centers in the brainstem if syringobulbia is involved.
And the severity of these complications seems directly linked to the extent of that cord damage and the neurological deficits the person has.
Exactly. The notes emphasize that the more extensive the myelopathy, the more severe the potential complications are likely to be. And this really brings us back full circle to that crucial point. Early intervention in symptomatic patients generally improves outcomes and hopefully prevents some of these severe complications. It's all about trying to limit that irreversible damage to the spinal cord.
Wow. Okay, we've really mapped out the whole journey here, digging deep into your notes, starting from the basic definition, looking at the numerous potential causes and how that fluid cavity actually forms, then through what it looks like clinically, those key distinctive features, how we confirm it with MRI, how we manage it based on the cause and symptoms, and finally what the potential future holds in terms of prognosis and complications.
Yeah, we've definitely covered the key ground and hopefully highlighted those really distinctive features like that shawl-like sensory loss, the absolute necessity of MRI for diagnosis, that critical link between identifying the cause and guiding treatment, and perhaps most importantly, the significance of timely intervention to try and prevent severe, permanent complications. These are definitely the high-yield points to take away for your revision.
So just thinking about everything we've discussed and the fact that even with these detailed notes, the notes themselves say the exact mechanisms aren't fully understood and that the prognosis depends so heavily on catching it early and intervening. What does that tell us, really, about the ongoing challenges with a condition like this, even with our current knowledge?
That's a great point. I think it highlights that while we have effective strategies, particularly for addressing the underlying mechanical issues surgically, there's still a fundamental need for a better understanding of the disease process itself, the pathophysiology at a deeper level. And perhaps more critically for clinical practice and revision, it underscores the ongoing importance of high clinical awareness and suspicion for early diagnosis, even for conditions considered rare like this, because that window for potentially preventing irreversible damage seems so crucial.
Absolutely. Timeliness is key. And for you, the listener, working through your revision, practicing applying this knowledge is really the essential next step now.
Exactly. Reviewing these points is one thing, but testing your recall and your ability to apply it in practice questions is vital. Your sources and this deep dive provide the foundation. For comprehensive practice materials, including lots more questions covering topics just like syringomyelia and how it might present in an exam scenario, you can find excellent resources over at passthemsra.com. And if you're just starting out or maybe want to test the waters with some free practice questions first, freemsra.com is a great place to get going. Both sites are designed specifically to help you lock in these high-yield points for your exams.
Fantastic. Well, thanks for taking this really focused deep dive into syringomyelia with us today, using your revision notes as our guide. Hopefully it's helped solidify those key facts for you.
Keep testing yourself. Keep exploring those resources. That focused revision really will pay off.
We'll catch you on the next dive.